Welcome to the deep dive. This is where we grab your source material, plunge right in, and pull out the absolute core of what you need to know, the surprising facts, the key connections, and the high-yield insights that actually stick. Today, we're diving deep into a specific clinical condition, especially relevant if you're, hitting the revision hard for exams like the MSRA, or frankly, just want to feel solid on a common and important diagnosis. You've shared some comprehensive revision notes, and our mission is to unpack them into a really clear, easy-to-remember overview for you.
Exactly. We're tackling acute pyelonephritis. Think of this deep dive as sort of cutting through the density of the notes to give you the absolute essentials, defining the condition, understanding who gets it, how it happens, how we spot it, how we treat it, and what can potentially go wrong. All geared towards maximum recall.
Okay, let's unpack this then. So to start at the beginning, what exactly is acute pyelonephritis? How is it defined in these notes?
Well, what's really insightful right from the start is the definition itself gives us the core features. It's defined as a bacterial infection of the kidney. And crucially, it involves inflammation specifically of the renal parenchyma, which is, the functional kidney tissue.
Right, the main kidney substance.
And the renal pelvis, that sort of funnel-shaped structure that collects urine.
So it's definitely not just like a standard bladder infection, a simple cystitis. It's higher up.
Precisely. Yeah, this is the infection that has traveled higher up, reaching the kidney tissue itself. It's characterized by clinical symptoms, the ones that bring someone in, and objective evidence of infection when we run tests.
Got it. So bacteria in the kidney tissue causing inflammation, how do those bacteria typically get up there? What's the route?
The notes list a few pathways. The most common, by far, is ascending from the lower urinary tract, basically. Bacteria climbing up from the bladder. That's the main one. Less commonly, they can arrive via the bloodstream from an infection elsewhere, or very rarely, through the lymphatic system. But honestly, that ascending route is the one to keep front of mind.
Are all cases the same, though, or are there different levels of, complexity?
That's a really important distinction the notes make. Uncomplicated versus complicated pyelonephritis. Uncomplicated is typically in healthy, non-pregnant women without any underlying kidney or urinary tract issues. Straightforward, usually.
Right.
Complicated cases are those where there are factors making it harder to treat or more likely to cause issues, things like immunocompromised patients, or importantly, all male patients.
Oh, really? All men?
Yeah. Regardless of other factors, they're often classified as complicated just because it's much less common in men, suggesting there might be an underlying reason.
Interesting. And which bacteria are usually the culprits when this happens, the usual suspects?
Absolutely. The usual suspects are bacteria commonly found in the gut. Escherichia coli, or E. coli, is overwhelmingly the most frequent cause. Can't stress that enough.
E. coli, okay.
But Klebsiella, Proteus, and Enterococcus species are also common players. The notes also list less common ones, mycobacteria, yeasts, fungi, opportunistic pathogens. And it's key to remember these because they become much more relevant in those complicated patient groups we just mentioned, like someone who is immunocompromised.
Makes sense. The notes also mention something about this not just being an acute problem, but potentially leading to long-term issues down the line.
Yes, exactly. And this is where the short-term issue connects to the bigger picture of kidney health. The notes highlight that repeated acute attacks of pyelonephritis, especially if not managed well, can unfortunately lead to chronic pyelonephritis.
And that means?
That involves ongoing renal tissue destruction and scarring, and can eventually impair kidney function long-term. So it's serious.
Okay, so it's a bacterial invasion, usually from below, causing inflammation and potentially scarring. When we think about why someone gets this, beyond just encountering the bacteria, who is more vulnerable, what are the key risk factors? The notes list quite a few.
Yeah, this is a vital section for identifying patients at higher risk or understanding why someone might have a more complicated course. The notes provide a really comprehensive list, and it's helpful to sort of group them conceptually.
Okay, how would you group them?
Well, first, think about the plumbing. Anything that affects the normal flow or structure of the urinary tract. Female anatomy is a big one due to the shorter urethra, makes it easier for bacteria to get up there. Urinary tract abnormalities like stones or vesicorectal reflux VUR, where urine flows back up from the bladder to the kidneys. That's a problem.
Reflux, yeah.
Obstruction anywhere in the urinary tract, maybe from an enlarged prostate in men, kidney stones blocking things, or even neurological conditions like a neuropathic bladder that impair emptying. If urine sits around, bacteria can multiply.
Okay, so plumbing issues, what else?
Then think about underlying states. Pregnancy causes physiological changes in the urinary tract that increase risk. A history of recurrent UTIs, obviously indicates a predisposition.
Makes sense.
Immunity matters. Being in an immunocompromised state significantly increases vulnerability, not just to pyelonephritis, but to those less common bugs too.
Right, the fungi and things.
Exactly. Medical interventions are another big category. Using medical devices like urinary catheters or stents bypasses natural defenses, a major risk factor.
Catheters, definitely.
And finally, certain underlying health conditions. Diabetes is a huge one, making patients prone to infections and potentially more severe ones. Menopause is listed, partly due to changes that can affect the urethra. Renal calculi, kidney stones again, can obstruct flow and provide niches for bacteria. Primary biliary cirrhosis is also listed, which is interesting, highlighting that systemic conditions can play a role.
Wow, it's a lot to remember. So basically, anything that disrupts the normal one-way street of urine flow, lowers your defenses, or provides a hiding place for bacteria seems to be the common thread. Spot on. If you can think about those categories, anatomy, obstruction flow issues, immune status, history, foreign bodies, and systemic illness, it helps structure that long list of risk factors for recall. Much easier than just memorizing a list.
Okay, helpful. We've talked about what it is and who gets it. Now, the pathophysiology. How does the body actually react once those bacteria invade the kidney tissue? What happens inside?
Right. The notes describe a pretty clear process. The bacteria ascend the tract, they reach the kidneys, and then they need to stick to the lining, the urothelium.
They adhere.
Yeah, adherence is key. Then the crucial step is they invade the renal parenchyma, the kidney tissue itself. They get into the kidney.
And that invasion is what causes all the trouble, the symptoms.
Yes, that's the trigger. It sets off a significant inflammatory response. This leads to swelling or edema, a rush of immune cells,
Right.
white blood cells trying to fight the infection.
Right.
And if it's severe, it can even lead to localized collections of pus, forming abscesses within the kidney tissue. Little pockets of infection. Nasty. And if that inflammatory process isn't stopped by treatment.
The notes are very clear. Untreated or inadequately treated inflammation and tissue invasion can result in significant renal scarring and potentially chronic kidney damage over time. This really underlines why prompt and effective treatment is so important.
Definitely. Moving on. If someone comes in feeling really unwell with that pain in their back or side and a fever, pyelonephritis is definitely high on the list. But what else could it possibly be? This differential diagnosis section looks pretty extensive in the notes.
It is, and this is a really critical area for clinical practice and revision thinking through the possibilities. You have to. The key is that classic presentation. Loin pain, fever, maybe nausea. What else causes pain in that area? Sometimes with systemic symptoms like fever.
So what's on the list?
Well, the notes list a lot, and again, grouping them helps avoid missing things. Think about other abdominal or pelvic organs first. Appendicitis can sometimes present with flank pain, cholecystitis, gallbladder, diverticulitis, or other intra-abdominal abscesses.
Okay, other gut stuff.
Then specifically in women, you must consider gynecological causes, some of which are absolute emergencies. Ectopic pregnancy is vital not to miss, can present with pain and collapse. Endometritis, oophorytis, pelvic inflammatory disease, PID, salpingitis, all these can cause lower abdominal or pelvic pain and fever, sometimes radiating.
Right. Gyne causes are key in women.
In men, prostatitis can cause fever and discomfort, but usually more pelvic or perineal pain, but worth considering. Back to the urinary tract, but not infection of the kidney tissue itself. Kidney stones, nephrolithiasis, are a classic cause of severe loin pain, often colicky, maybe with blood in the urine. Stones can sometimes get infected secondarily, leading to pyelo, or just cause severe pain mimicking it.
Stones are a big mimic, yeah.
Also things like interstitial cystitis, urethritis,
Yeah.
even structural issues like vesicovaginal or ureterovaginal fistula or vesicuritic reflux, VUR, which we mentioned is a risk factor, can sometimes present atypically or contribute.
And the really serious stuff.
Don't forget the really serious but less common things. A ruptured abdominal aortic aneurysm, TRAVEL-A, can present with back or flank pain and shock, a surgical emergency, obviously. Papillary necrosis, where bits of the kidney die off, often seen in conditions like sickle cell disease or with heavy NSAID use, can cause pain and symptoms.
Okay.
The notes also list STIs, though they typically present with lower urinary tract symptoms or discharge, rather than the classic pyelonephritis triad. but maybe something to consider in the background.
Wow, that list really highlights how broad your thinking needs to be when someone presents with these symptoms. You have to consider everything from a, relatively simple stone to a life-threatening emergency like in AAA or ectopic.
Absolutely. And grouping them urological, gastrointestinal, gynecological, especially in women, vascular can help ensure you don't miss something crucial, particularly those surgical emergencies. It's about having a system.
Okay, very useful. We talked about who's at risk, but looking at the population who actually gets this most often, is there a typical demographic? The notes mention some epidemiology.
Yeah, the epidemiology provides some interesting patterns. Pyelonephritis affects both genders, obviously, but there's a significantly higher incidence in women.
Which makes sense with the anatomy.
Exactly. Ties back directly to the shorter female urethra and the ease of bacteria ascending.
And age-wise,
Incidence peaks in younger women, specifically between 15 and 29 years old. That's the highest group. However, infants and older individuals, say over 65, also show higher rates compared to other age groups.
why them?
Well, the very young have developing immune systems and maybe potential anatomical issues, while the elderly often have higher rates of comorbidities, prostate issues in men causing obstruction, and more medical device use like catheters.
You mentioned it's less common in men generally. When do we tend to see it more often in men?
It is less common overall, yeah, but the notes point out it's more frequent in male neonates, often associated with underlying structural problems in their urinary tract. And notably, the incidence in men over 65 years old actually rises to match that of women.
Ah, interesting. Because of prostate issues mainly.
Yeah, likely due to the increased prevalence of things like prostatic hypertrophy causing obstruction, bladder emptying issues, and catheter use in this older male age group. It sort of levels the playing field again, risk-wise.
Okay, so we know what it is, how it happens, who gets it, and what else it might be. What does it actually feel like for the patient? What are the classic signs and symptoms we're looking for when someone comes in?
Right, the clinical presentation. The notes list this clearly, and it's often quite striking, with symptoms typically coming on rapidly, quite suddenly. Key symptoms include high fever, often with chills, proper shaking chills, rigors,
Rigors, okay.
pain in the flank area, that's the side of the back, usually between the ribs and hip. It can be on one side, unilateral, or sometimes both, bilateral.
Mhm.
Patients often also have lower urinary tract symptoms that might have started first, like urinary urgency, frequency, and painful urination or dysuria.
So burning, needing to go often.
Exactly. And then nausea, vomiting, and just a general feeling of being really unwell, malaise are also very common. They feel rough.
Is there a core set of symptoms that really screams pyelonephritis? A classic picture.
Absolutely. The notes highlight the classic triad, which is incredibly high yield for recognition. If you remember one thing about presentation, remember this: loin pain, nausea and vomiting, and fever.
Loin pain, nausea, vomiting, fever.
That's it. If you see that combination, acute pyelonephritis should jump right near the top of your differential diagnosis list. Maybe think FLN, fever, loin pain, nausea. Helps it stick.
FLN. Good tip. And what about kids? Are their symptoms always the same as adults?
That's a critical point mentioned specifically in the notes for pediatrics. In young children and infants, symptoms can be much less specific, much more vague.
How so?
They might just present with fever, irritability, poor feeding, maybe vomiting, or just looking generally unwell, lethargic, without the clear loin pain or specific urinary symptoms you see in adults. This makes clinical suspicion and, importantly, getting that urine sample for culture even more vital in this age group. Don't rely on classic symptoms in the very young.
Okay, really important point for parents. So we suspect it based on symptoms, maybe the triad, maybe just fever in a baby and the risk factors. How do we actually confirm the diagnosis and check how severe it is? What investigations are essential?
Right, investigations. The notes outline the key steps here. The absolute cornerstone, emphasized repeatedly, is getting a urine culture. Midstream urine, ideally, or catheter sample if needed.
And critically.
Critically, this should be done before you start antibiotics. Cannot stress that enough. It's non-negotiable because it tells you exactly which bacteria is causing the infection and, vitally for treatment later, which antibiotics it is sensitive or resistant to. You need that info.
Before antibiotics, got it. What other tests are usually needed?
A urine analysis, or dipstick test, is also really important. It gives you a rapid snapshot looking for nitrites, leukocytes, signs of white blood cells, and maybe blood in the urine, which are strong indicators of infection. It's quick, but doesn't replace culture.
Okay, dipstick and culture. What about bloods?
Baseline bloods are also essential. This includes things like a full blood count, FBC, to check the white cell count for signs of infection systemically. And importantly, kidney function tests urea and electrolytes, UNEs, or renal profile to see if the infection is impacting kidney function. Also, inflammatory markers like CRP.
And blood cultures.
Yes, blood cultures are also recommended, especially if the patient seems quite unwell or septic. They can be positive in a significant proportion of patients. The notes say 15–30% might be positive, indicating the bacteria have spread into the bloodstream, bacteremia. That definitely influences management decisions.
Okay. Is imaging always necessary? Do we need to scan the kidneys in everyone with suspected pyelo?
Good question. The notes indicate that renal ultrasound is often necessary in suspected cases. It's useful, non-invasive, and helps to look for complications like obstruction, say from a stone, or hydronephrosis, or maybe an abscess starting to form.
So ultrasound is common.
Yeah. The notes mention that imaging protocols vary slightly between children and adults. For children, ultrasound is usually the definite first-line imaging. For adults, a CT scan, specifically CT-KUB, kidneys, ureters, bladder, might be used, especially in cases where the diagnosis is uncertain, or, crucially, if the patient isn't responding well to the initial antibiotic treatment after, say, 48–72 hours.
Why CT then?
CT is much better at picking up abscesses, looking for stones, or identifying anatomical issues. So if they're not getting better, you need that better look. Other more specialized imaging like a DMSA scan, which is good for looking for kidney scarring later on, and MRI are mentioned for specific, less common situations. A renal biopsy is rarely needed for acute pyelonephritis itself.
So it sounds like the investigations are sort of tier. Everyone gets urine tests, usually bloods too, and then imaging is often needed, typically ultrasound first, maybe CT if things aren't straightforward.
Exactly. You tailor the investigation strategy based on the clinical presentation, the severity, whether they have risk factors for complications, and how they're responding to initial treatment. It's not one size fits all.
Makes sense. Once we've confirmed the diagnosis or are strongly suspecting it, how do we treat it? What's the management approach outlined in the notes? Prescribing, non-prescribing?
Right, management. The absolute core of management is antibiotics. No surprise there. You start empirically, meaning you pick an antibiotic likely to cover the common bacteria like E. coli based on local resistance patterns and guidelines. You don't wait for the culture result to start treatment if you suspect pyelo.
What kind of antibiotics typically?
The notes list common empirical choices for adults, like ciprofloxacin, which is a quinolone, or coamoxiclav. Then, once you get the sensitivities back from that urine culture you sent earlier, usually takes a couple of days, you adjust or tailor the antibiotic if needed to specifically target the identified bacteria effectively and maybe narrow the spectrum. Trimethoprim is listed, but often requires sensitivity confirmation first, as resistance rates can be quite high in some areas.
Okay. And for children?
For children, the notes suggest coamoxiclav is a common first choice empirically, with something like cefixime as an alternative, if there are penicillin allergies, for example. Again, always check local guidelines.
Is it just antibiotics, or is there other important supportive care involved?
Oh, supportive care is vital,
Yeah.
absolutely, especially if the patient is quite unwell. Intravenous fluid replacement 5 fluids is key, particularly if the patient is dehydrated from fever, not drinking, nausea, or vomiting.
Yeah.
Rehydration is crucial.
So it's right.
Analgesia is important for pain relief, paracetamol. Maybe NSAIDs if appropriate, sometimes stronger options if needed. And antiemetics, like cyclizine or ondansetron, are needed if they have significant nausea or vomiting, partly to help them tolerate oral fluids and medications later.
Okay. Do all patients need to be admitted to the hospital, or can some be managed at home?
No, not everyone needs admission, and this is an important point for primary care and A&E. Many uncomplicated cases can be managed safely in the community with oral antibiotics, provided the patient is otherwise stable, can reliably take and tolerate oral intake, fluids and meds, and has good social support and follow-up arranged.
For some definitely need to come in.
Absolutely. The notes provide clear criteria for hospital admission because pyelonephritis can turn serious quickly. These include any signs of severe illness or sepsis, like low blood pressure, high heart rate, high respiratory rate, confusion. Also, significant dehydration or persistent vomiting, preventing oral medication, severe pain that's not controlled, any suspicion of urinary tract obstruction.
And specific groups.
Yes. Underlying comorbidities like poorly controlled diabetes or being immunocompromised often warrant admission. And importantly, all pregnant women with pyelonephritis should be admitted, as should infants under 3 months of age. They are high-risk groups.
Got it. Pregnant women and young babies always admitted. How long is the antibiotic course usually?
The notes generally refer to local guidelines for duration, but courses are typically around 7 to 14 days. It could depend on the antibiotic chosen, the severity of the infection, and whether it's classed as uncomplicated or complicated. For therapy might be used initially in hospital, then switched to oral.
The notes also mention some tougher, more complicated versions of this infection, chronic and emphysematous.
Yes, they specifically highlight chronic pyelonephritis, which we touched on earlier, that scarring and kidney damage that can result from repeated or inadequately treated episodes. And then there's the rare but very serious emphysematous pyelonephritis.
What's that exactly?
This is a necrotizing infection, meaning it causes actual tissue death within the kidney, and it involves gas formation in the kidney tissue, which you can see on imaging like CT. The notes specify it's strongly associated with diabetes and urinary tract obstruction.
And why is it so serious?
It's crucial because it often doesn't respond well to antibiotics alone. It's a surgical emergency in many cases and may require urgent intervention like inserting a tube directly into the kidney to drain pus and gas collections, a percutaneous nephrostomy, surgical drainage, or even removing part or all of the affected kidney nephrectomy in severe life-threatening cases. Much higher mortality.
Wow, okay, so surgery might be needed, but usually only in those really complicated cases like abscesses or this emphysematous type.
Exactly. Surgery is not standard for typical acute pyelonephritis. It's reserved for those rare, complicated situations, draining large abscesses, relieving obstruction that's driving the infection, or dealing with emphysematous pyelonephritis.
Okay, so with appropriate treatment, antibiotics, fluids, maybe drainage if needed, what's the likely outcome or prognosis? Generally good.
Yes, the notes are quite reassuring regarding prognosis for typical uncomplicated cases treated properly. With prompt and appropriate antibiotic treatment, the prognosis is generally favorable. Symptoms usually start to improve within 48-72 hours, and serious complications can often be prevented. Most people make a full recovery.
And the flip side, what happens if it's not treated effectively or treatment is delayed?
This is where the prognosis can be much worse, unfortunately. Untreated or inadequately managed cases can lead to significant morbidity and even mortality, though thankfully death is rare now with antibiotics. But the notes explicitly list severe outcomes like progression to sepsis.
Which is life-threatening.
Exactly, a life-threatening systemic infection, formation of kidney abscesses, or spread of infection to the space around the kidney, parenephric abscess. And as we discussed, long-term renal scarring and the potential for developing chronic kidney disease later on. So delays matter.
That leads right into the potential complications. What are the specific bad things we need to watch out for or consider as potential outcomes of acute pyelonephritis, especially if it's severe or complicated?
Yeah, this is a key list to have in mind when managing these patients. The potential complications listed are sepsis, that systemic inflammatory response, localized collections of pus like a parenephric abscess or a renal abscess, including that very severe emphysematous pyelonephritis form we just talked about, acute papillary necrosis, where parts of the inner kidney die off. Specific pregnancy complications can occur if pyelonephritis happens during pregnancy, like preterm labor. And overall, renal function impairment, which can sometimes be acute during the illness, but also lead to chronic impairment if there's significant scarring.
And just like with getting the infection in the first place, are some people more likely to develop these nasty complications than others? Are there risk factors for complications?
Yes, absolutely. The notes provide a specific list of risk factors for developing these complications. These overlap somewhat with the general risk factors for getting pyelo, but they really highlight factors associated with more severe disease or worse outcomes.
Such as?
This list includes being severely ill at presentation, for example, signs of sepsis, being older, specifically age over 65, having underlying structural abnormalities in the renal tract or foreign bodies like stones or stents, having diabetes mellitus that comes up again and again. Pregnancy itself is a risk factor for complications, having had a recent renal transplant, especially within the first 3 months, and other immunocompromised states like AIDS or being on immunosuppressant drugs.
Okay, so recognizing those factors really helps identify the patients who need closer monitoring, maybe admission even if they look okay initially, or perhaps broader initial antibiotic cover.
Exactly. These are the red flags for potential trouble. Recognizing these helps you stratify risk and tailor the intensity of management and monitoring.
Finally, prevention. Especially for people who seem to get this repeatedly or those high-risk groups, can we do anything to stop it from happening in the first place or reduce the frequency?
Yes, the notes mention prophylactic treatment, so preventative antibiotics, in specific situations. For women who experience recurrent UTIs, often defined as, say, 3 or more symptomatic infections per year, low-dose prophylactic antibiotics taken daily or postcoitally can be considered. Often something like trimethoprim or nitrofurantoin is used.
To try and stop the cycle.
Exactly, to try and prevent those lower UTIs from ascending and becoming pyelonephritis.
And what about for children who we said are at risk of scarring? Is prophylaxis used there?
For children, the notes state that antibiotic prophylaxis is generally reserved for those considered at the highest risk of complications and long-term kidney damage. It's not routine. This includes children with significant grades of vesicorectal reflux, VUR, those with recurrent symptomatic UTIs that have caused pyelonephritis, or those who already show evidence of renal scarring on imaging like a DMSA scan. So it's a more targeted approach for the most vulnerable kids, usually under specialist guidance.
Okay, that was a really solid deep dive into acute pyelonephritis, pulling out all the essential information from the notes you provided. We've defined it, covered the causes, the pathophysiology, how it actually happens, who's at risk, what symptoms to look for, the key investigations and management steps, and crucially, the potential outcomes, complications, and a bit on prevention.
Yeah, and by structuring it logically like that and highlighting those key connections, like how risk factors influence both getting the infection and the likelihood of complications, or the importance of that classic triad for diagnosis, we hope it makes this complex topic much clearer and easier to recall for revision or when you encounter it in practice.
It really drives home that this isn't just a simple infection, is it? It's a potentially serious condition with significant long-term consequences if not managed appropriately, especially in those vulnerable patients we identified. And understanding those differential diagnoses is also absolutely key to not missing something potentially even worse.
Definitely. If we connect this to the bigger picture, mastering topics like pyelonephritis isn't just about passing exams, although that's important. It's really about being able to quickly assess a potentially unwell patient, consider the right diagnoses, understand the urgency, and initiate appropriate management to prevent serious harm. Knowing those high-risk groups and potential complications is just vital for patient safety.
So what does this all mean for you listening? Perhaps the provocative thought to leave you with is this. Given the potential for progression to sepsis and chronic kidney damage, how does really understanding the pathophysiology and risk factors of pyelonephritis influence your threshold for investigating further, or even admitting a patient who presents with what initially might seem like just a particularly bad UTI? Does identifying certain risk factors immediately elevate your level of concern and change your plan? Something to think about. We certainly hope this deep dive has been incredibly helpful for you. For more resources to help you prepare, definitely check out PassTheMSRA.com.
And explore freemsra.com as well for additional materials and practice questions. Lots of good stuff there.
Until next time, keep diving deep.